So my name's Jenny. I'm a midwife at Warwick Hospital, and I'm going to speak about antenatal perineal massage and pelvic health outcomes. Can you go forward 2 slides? So our aim was to improve pelvic health outcomes by increasing antenatal perineal massage and looking at increasing staff knowledge and confidence to talk about perineal massage, increasing women's confidence to undertake it, and then increase availability and accessibility of resources. Can you go back a slide, please, Rachel? So pelvic health dysfunction and perineal trauma is really common in the perinatal period, and it's currently on the national agenda thanks to the work of all the organisations I've screenshotted here. And we were particularly interested in OAC. So the national average OAC is around 3%, and our trust sits around that, slightly higher than our neighbouring units. And we know that OAC are consistently linked to pelvic health dysfunction in the short and long term, such as incontinence and pain, as well as other health outcomes like poor mental well-being. Can you go forward to, and then we should be back on normal slides. So why antenatal perineal massage? It's cheap, it's low risk, and it's green and sustainable, and it's woman-led. And it has really good evidence behind it that it improves pelvic health outcomes in the long and short term. So reducing perineal trauma such as OAC, reducing active second stage, and improving postnatal outcomes like improved wound healing and reduced pain. And these benefits improve sustainability. So less perineal repairs, less follow-up appointments, less use of health services, less incontinence products, and an improved birth experience and quality of life for women. Next slide, please. So we had a look at what was currently happening. We did a couple of surveys and we did some audit and some data. So the staff felt that they routinely discuss antenatal perineal massage with women, but they did face barriers, not having enough knowledge or confidence or time, and lack of resources to signpost women to. And conversations were obviously late in pregnancy, not giving enough time to effectively undertake perineal massage or for any follow-up or troubleshoot conversations. Service users, so they felt differently to midwives. They didn't feel like they got information from midwives, and they actually got information from other resources. About a fifth-ish of women that we surveyed did undertake perineal massage, but they had barriers, not feeling confident, not knowing what they were doing, not knowing whether it was important, should they prioritise it or not, practicalities, reaching, discomfort. And when they did undertake it, they weren't always sure they were doing it right. We looked at some objective measurements for whether the trust was giving information to women, particularly with the survey discrepancy. And we found that it was the least utilised of all perineal protection techniques. So only 5.6% of audited notes had a documented antenatal conversation about it. And only a few hundred women looked at the resources on BadgeNet and the trust birth classes. So overall, there was poor information sharing and poor knowledge and poor uptake. Next slide, please. So our intervention, could training increase midwife confidence and knowledge, making their conversations more effective and therefore increase antenatal perineal massage uptake? So we did a 30-minute face-to-face training session for self-selected cohort of community midwives, which was a PowerPoint discussion, kind of Q&A, and also a video that we'd made of some mock antenatal appointments and perineal massage demo. And then there was a WhatsApp group as well for ongoing support for the midwives. We then asked these midwives to have as many conversations as they could with women in the third trimester about perineal massage and signpost them to a page that we designed with the Real Birth Company platform, linking into local and national resources. Service users were then asked to have a survey after the conversation to evaluate that conversation and also to say their intention of undertaking perineal massage. Next slide, please. So our findings, we did a staff survey and a focus group, and we found that the training did change practice. Staff discussed it more often and at earlier gestations, and it did remove barriers such as knowledge and confidence, and also reducing time spent by signposting to resources. It did alleviate some of the time pressures. Signposting to national resources did help women realise that it was an evidence-based, like recommended health intervention, and increased its importance for them and normalised it for them. We did have low staff buy-in and risk factors for OAC and troubleshooting conversations. Confidence and knowledge wasn't improved as much with staff. Service user survey, so it did increase knowledge and confidence and intention to undertake massage, and they really valued having that conversation with their midwife and the midwife initiating the conversation and signposting to resources, but we did have a really poor response rate. Data and audit, so the midwives felt they'd spoke to about 45 women, and we had our real birth company page was accessed 19 times. So this was an increase in the number of women accessing resources within the study period. We didn't see a change in OASI rates, but we didn't expect to, because the data for January won't reflect the cohort of women who'd had the conversations who haven't yet given birth. So overall training did seem to increase the quantity and quality of conversations, but we're unsure whether this is going to increase antenatal perineal massage uptake, maybe because of the short time frame of the project, but also because it's difficult to get easy and accurate data on rates of perineal massage. Next slide, please. So some of our outcomes we looked at if we can increase perineal massage, what would happen? So if we had 50% of women undertaking perineal massage, with a risk reduction of 0.36 from a systematic review, this would be 14 less OASI cases per year. So social, we looked at the RCOG green top guidance of women being asymptomatic after a year after OASI, and this would be 3 to 6 less individuals per year that had pelvic health dysfunction 1 year after an OASI. It doesn't quite take into account background pelvic health dysfunction rates. Environmental, we looked at the carbon footprinting, and that was a table savings of 1,887 kilo carbon dioxide equivalent. Financial, so we did pathway mapping and NHS tariff costs to figure that out, and it was about 66,000 savings for 14 less OASI. And then clinical, I based this on clinical time. So the time it would take to train all the staff, the time it would take to have a 10-minute conversation with women, and the time it takes for OASI care, so a full theatre team and inpatient stay, follow-up appointments. And our intervention would increase clinical time by about 46 hours, and we're looking at 2,500 hours. So it's not really significant, and we could probably play with it a little bit. Last slide, please. So the forecasting outcomes really helps galvanise as to what we could achieve. So we know that we really need to change the culture. Antenatal perineal massage is one of the key interventions in reducing OASI rates and pelvic health dysfunction. But to change culture, we do know that it takes time, commitment, and repeated exposure. So we do know there's a journey ahead of us, but we are lucky that we've got an LMNS pelvic health project ongoing, which this links in with. We're going to add in our training into our core competency framework for the year, although a shortened version, and we're going to try and get some drop-in sessions for troubleshooting and to support staff. We want to continue to build the library of resources on our real birth company page and our local birth classes, and continue to audit OASI. Thank you.
Brilliant. Thanks, Jenny. Any questions from the judging panel?
Rani, are you speaking because you're on mute, I think?
Yeah, it's a bit noisy here, so I'm trying to keep on mute. Really pleased to hear a presentation on OAC. You know how passionate I am about preventing this. My question is, how do you know it is the perineal massage that's reducing your OAC rates? Because that is probably just one component of a whole bundle. And are you doing the other things like perineal support, etc.?
So in our audit, we were quite pleased with how we're doing with the other components of the OASI care bundle and other prevention techniques, and it was just this that was really low. So we're kind of putting our efforts into this direction, and then hopefully to see some change. So we can't ever tell that it was directly linked to this, but the other components seem to be doing well.
So you're taking a more holistic view rather than just one aspect, not just one intervention. You're doing everything.
Yeah, so we've done other things before, and this was just the one that was really lagging behind, that we felt, okay, we need to direct some attention and resources here.
Thank you.
Any other questions from the judges?
I think there's one in the chat.
Yeah. Do you want me to answer in the chat or answer here?
I think it's an important one.
Yeah.
Yeah.
So we did look at service user surveys, and we've also looked at, when we audited our AC, we did look at our demographics and compare them to our booking demographics to see whether certain groups are overrepresented or underrepresented. We didn't, within the timeframe of the project, get enough information about demographics to know if we were hearing from the right people. As part of our wider LMNS pelvic health project, we really are trying to get into different communities and different areas for pelvic health generally, and this would just sit within them completely. But I think that's a really, really interesting question, and it's something that within the literature as well is less explored about. Why is it that women wouldn't do this? And that was a really interesting question.
Thank you so much, Jenny. And we're going to move on, so last but definitely not least, to our final team for today. So we have Minnie here to speak on behalf of our second team from Imperial NHS Trust. Thanks, Minnie.
Hello, thank you. Can you
Yes,
see
we
me?
can see.
Hey, someone. Good, okay. Perfect. So hello everyone, I'm Manny. I'm currently working as a maternity safety improvement